Hello, it's a pleasure to be here again with you, and this time we will discuss the main reasons why sometimes vitamin D doesn't work, which in turn are the reasons why various randomized controlled trials have failed to confirm the health outcomes attributed to vitamin D in epidemiological studies. But first, let's briefly review the metabolism of vitamin D. Vitamin D can be synthesized in the epidermis by the action of UVB radiation on 7-dehydrocholesterol, or it can be obtained exogenously via food or supplements. And when vitamin D reaches the liver, it will undergo an hydroxylation at carbon 25 thanks to 25-hydroxylase, which may be one of various cytochrome P450 enzymes. And the resulting compound is 25-hydroxyvitamin D, also known as calcidiol or calcifediol. And after being discharged into the circulation, this molecule, 25-hydroxyvitamin D, will travel to the kidney, where it will be converted by the action of the enzyme 25-hydroxyvitamin D 1-alpha hydroxylase, also known as CYP27B1, which is located in the mitochondria of proximal convoluted tubular cells, into 1-alpha 25 dehydroxyvitamin D, also known as calcitriol. And this molecule, calcitriol, which is considered the active form of vitamin D, will serve as a ligand for the vitamin D receptor expressed in the cells of several extrarenal tissues. Therefore, kidney-derived 1-alpha 25 dehydroxyvitamin D is expected to exert numerous endocrine actions in the cells of different tissues that express the vitamin D receptor. Moreover, we know that several cells, including immune cells, express CYP27B1, which is 1-alpha hydroxylase, and can therefore synthesize 1-alpha 25 dehydroxyvitamin D or calcitriol from 25-hydroxy-D. This means that vitamin D has not only several endocrine but also paracrine and autocrine effects, thus regulating a wide variety of physiological functions, including bone and muscle metabolism, as well as innate and adaptive immune responses. And in accordance with this, there is evidence from animal experiments and epidemiological studies linking vitamin D deficiency with rickets, muscle weakness and osteoporosis, but also with infectious diseases and autoimmune diseases. And since one of the main topics of this Congress is autoimmunity, let's just briefly look at some of the meta-analysis and systematic reviews that have linked vitamin D with autoimmune diseases. Here we have one that concludes that there is an association between circulating 25-hydroxy-D, which is the biomarker used to assess vitamin D status, and Hashimoto's thyroiditis. And here we have another that concludes that there is an inverse association between serum vitamin D and rheumatoid arthritis disease activity. Here we see another systematic review and meta-analysis on lupus that concludes that patients afflicted with this disease have significantly lower 25-hydroxy-D levels compared to healthy controls. Finally, we have this systematic review and meta-analysis that concludes that low vitamin D levels are a risk factor for multiple sclerosis. We also have various lines of evidence linking vitamin D deficiency with various types of cancer. For instance, we have this systematic review and meta-analysis of observational studies concluding that there is an association between vitamin D deficiency and breast cancer. And here we have another one that has found an association between circulating 25-hydroxy-D levels and survival in patients with colorectal cancer. And here we have a meta-analysis of prospective cohort studies concluding that 25-hydroxy-D levels are inversely associated with cancer mortality risk. And finally, we have this systematic review in meta-analysis that concludes that there is an association between 25-hydroxy-D levels and survival from multiple cancers. Then we also have evidence linking vitamin D deficiency to the metabolic syndrome, type 2 diabetes, and cardiovascular disease, to neurodegenerative diseases, and even psychiatric diseases. Nevertheless, randomized controlled trials paint a different picture. For instance, when we look at this meta-analysis published on Lancet Diabetes and Endocrinology in 2014, we see that vitamin D, with or without calcium, does not reduce skeletal or non-skeletal outcomes. Then we also have this other one published in JAMA in 2018, which is a systematic review that concludes that vitamin D supplementation alone or with calcium was not associated with reduced fracture incidence among community-dwelling adults. Then we have this other one published on JAMA Cardiology in 2019, which is a meta-analysis of 21 randomized controlled trials, which concludes that vitamin D supplementation was not associated with reduced major adverse cardiovascular events, individual cardiovascular endpoints, or all-cause mortality. And then we also have this other one published by Cochrane, which concludes that to date, which is 2018, very low quality evidence suggests no benefit of vitamin D for patient-important outcomes among people with multiple sclerosis. And we also have this other one, which is a meta-analysis and systematic review of randomized controlled trials published in 2021 that concludes that there is insufficient evidence to support the efficacy of vitamin D supplementation in breast cancer risk and change of mammography density. And this other one published in Nutrients this year has concluded that in clinical trials with large samples, vitamin D supplementation did not have any significant effect on primary outcomes, including cancer, cardiovascular events, and mortality. Finally, we have these two other systematic reviews and meta-analysis concluding that despite a few hundred systematic reviews and meta-analysis, a highly convincing evidence of a clear role of vitamin D does not exist for any outcome, or there remains little evidence to suggest that vitamin D supplementation has an effect on most conditions, including chronic inflammation. So why is that? Why do we see such conflicting results? We see that the in vitro studies, the animal experiments, the epidemiological studies all point in one direction, which is the link between vitamin D and multiple health outcomes. But when we look at randomized controlled trials, we do not see that link. And why is that? There are, in my view, multiple explanations. And these are also the limitations of clinical trials when applied to nutrients. First of all, not all clinical trials consider the baseline status of vitamin D. And remember that vitamin D status is assessed by measuring serum or plasma 25-hydroxyvitamin D. With that in mind, let's look at this graph. This curve here shows the response expected, Lil A, Lil B, and Lil C, for the same intake of vitamin D at 3 different baseline levels of 25-hydroxy-D, A, B, and C, with C being higher than B and B being higher than A. So when someone with this very low baseline level of 25-hydroxy vitamin D ingests this amount of vitamin D, the response will be null. Why? Because this amount of vitamin D is not enough to push this person with vitamin D deficiency into a sufficiency state. Nevertheless, when someone with this B level of 25-hydroxy-D ingests the same amount of vitamin D, the response will be adequate. Why? Because this baseline level of 25-hydroxy-D is already close to the optimal level. So this amount of vitamin D is enough to push this person into the optimal range of 25-hydroxyvitamin D. And we also see that giving additional amounts of vitamin D to someone who already has enough, and this is characterized by this C level of 25-hydroxy-D, will also produce a null response. So this is an S-shaped response curve that characterizes most nutrients, and this makes it clear that not giving enough to push a person with vitamin D deficiency, in this case the A level, onto the ascending limb of this response curve will not elicit any benefits. Likewise, giving additional amounts of vitamin D to someone who already has an optimal level is likely to also produce no beneficial effect. And this is so because, as we see in this graph, there is an inverse relationship between baseline serum 25-hydroxy-D concentrations and the magnitude of change in serum 25-hydroxy-D in response to oral vitamin D3 between 2,000 and 10,000 international units per day. So when you already have high baseline levels of 25-hydroxy-D, the change in your 25-hydroxy-D levels will be much smaller. So in randomized controlled trials where identical doses are given to everyone in the treatment arm without considering basal status of vitamin D, will not lead to measurable health benefits. So this is very important. We need to always measure the baseline levels of vitamin D before deciding to supplement or not supplement our patient, and also in order for us to decide the optimal dose. So before supplementing with vitamin D, assess serum or plasma 25-hydroxy-D to define the correct dosage. Another explanation for the conflicting results that we find in randomized controlled trials when compared to observational studies, animal and in vitro experiments, and another limitation of clinical trials is the fact that most randomized controlled trials have used different levels of vitamin D adequacy to stratify their analysis. So we have different 25-hydroxy-D thresholds. For instance, as you can see here in the US, the cutoff for sufficiency has been set at 20 nanograms per milliliter, whereas in the United Kingdom it is merely 10 nanograms per milliliter. On the other hand, the Endocrine Society, with members from over 120 countries, has set it at 30 nanograms per milliliter. And more recently, Kimball and Hollick have reviewed various lines of evidence and suggested that the optimal levels of 25-hydroxy-D for multiple health outcomes should lie between 40 and 60 nanograms per milliliter. This failure to ensure that the necessary thresholds are first defined and then reached and maintained during a clinical trial is a major confounder that explains on its own the lack of results found in various vitamin D trials. And when it comes to clinical practice, it is mandatory that we first define where do we want to go. So this means what are the optimal levels that we want our patient to reach through supplementation. And those appear to be 40 to 60 nanograms per milliliter. Another limitation of clinical trials, and also an explanation for why sometimes vitamin D works and sometimes it does not, is the use of inadequate dosing regimens. Let's look at some studies that illustrate this. Here we have a meta-analysis of randomized controlled trials concluding that daily or weekly vitamin D supplementation reduced the risk of acute respiratory infections, whereas bolus doses did not. And here we have also data from randomized controlled trials regarding rickets that concluded that low-dose daily vitamin D prevents rickets, whereas intermittent high-dose bolus does not. And then we have this randomized controlled trial in older women regarding falls and fractures that concluded that an annual oral administration of high-dose vitamin D resulted in an increased risk of falls and fractures. And why is that? Where is the explanation for this? What happens is that when you greatly increase vitamin D intake, you will have a very large variation in vitamin D levels and also in 25-hydroxy-D levels. And this can downregulate CYP27B1, 1-alpha hydroxylase, and hence decrease the synthesis of 1-alpha-25 dehydroxyvitamin D. On the other hand, it can upregulate CYP24A1, which will convert 25-hydroxy-D and also 1-alpha-25 dehydroxyvitamin D into molecules that can be subject to degradation. Another limitation of clinical trials, and also an explanation for why sometimes vitamin D doesn't work, is the use of one-size-fits-all approaches. Let's look at some examples. We start by the role of genetics. We know that most vitamin D is transported in the blood by vitamin D binding protein. This means that genetic variants that affect this protein could then affect the transportation of vitamin D. Also, there are genetic variants that affect 25-hydroxylases, 1-alpha hydroxylase, and the vitamin D receptor. Finally, certain genetic variants can affect 24-hydroxylase, which could then lead to an increase in the degradation of 25-hydroxy-D and also 1-alpha-25 dehydroxyvitamin D. As another example, we have obesity, which is highly prevalent in most industrialized countries. And we know that there is deposition and sequestration of vitamin D in body fat, and also that obesity can repress CYP2R1, which is a 25-hydroxylase, and this can lead to a reduction in 25-hydroxy-D levels. And this explains why overweight and obese people need 1.5 and 2 to 3 times more vitamin D to reach a 25-hydroxy-D level matching the one achieved by normal weight individuals. As another example, we have chronic inflammation, which can also lead to a decrease in 25-hydroxy-D levels. As a final example, demonstrating why a one-size-fits-all approach does not always work and why we need to take into account various confounding factors that can increase the need for more vitamin D in certain individuals, we have certain drugs that can upregulate 24-hydroxylase, hence increasing the degradation of 25-hydroxy-D and 1-alpha-25-dehydroxy vitamin D. These drugs are certain anti-epileptics, certain anti-neoplastic drugs, certain antibiotics, dexamethasone, certain anti-hypertensive drugs, certain antiretroviral drugs, certain endocrine drugs, and also certain herbal medicines such as kava kava and St. John's wort. So this means that we need to consider the various factors that can increase or decrease the need for vitamin D. Another major limitation of clinical trials, and also an explanation for why sometimes vitamin D does not work, is not taking into account the various nutrients that interact with vitamin D. For instance, we need magnesium for the synthesis of the vitamin D binding protein, and also for CYP2R1, which is a 25-hydroxylase, and for CYP27B1, which is 1-alpha-hydroxylase. And then we also need vitamin B2 for 25-hydroxylase and for 1-alpha-hydroxylase. So this means that whenever we decide to supplement our patients with vitamin D, we need to take into account magnesium and vitamin B2 intake and status. Another limitation of clinical trials is not considering sun exposure. For example, exposing arms and legs to the sun without sunscreen for half the time necessary to induce an erythema can lead to the synthesis of 2,000 to 3,000 international units of vitamin D3. And whole body exposure for the time necessary to induce erythema can lead to the synthesis of 10,000 to 25,000 international units of vitamin D3. This means that we need to take into account sun exposure, and this is not always taken into account in clinical trials. Another limitation of clinical trials is not considering the intake of vitamin D from foods. Although there are very few foods that really can contribute to an optimal vitamin D status, these have to be taken into account. So in conclusion, clinical trials have several limitations that preclude us from using them to make a decision regarding vitamin D supplementation. And these are not taking into account the baseline status of vitamin D, not taking into account the optimal 25-hydroxy-D levels, using inadequate dosing regimens, using one-size-fits-all approaches, not taking into account the various nutrients that interact with vitamin D, not considering sun exposure, not considering the intake of vitamin D from foods, and also the use of different assays to measure 25-hydroxy-D, which is a problem because different assays can produce different results. Finally, there aren't, unfortunately, long-term randomized controlled trials to test whether achieving long-term repletion of vitamin D may reduce the risks of the various chronic disorders that vitamin D deficiency may aggravate, such as cancer, autoimmune diseases, and cardiovascular disease. And I don't think there will ever be such a trial because leaving controls in a deficient state is unethical. So in summary, epidemiological studies have repeatedly associated vitamin D to various health outcomes, and this is in accordance with in vitro and animal studies, which in turn have shown that vitamin D can affect multiple physiological functions. Nevertheless, the evidence from randomized controlled trials is limited and conflicting. However, the fact that most randomized controlled trials fail to take into account the various confounding factors that we just discussed casts doubt on its results. This, coupled with the fact that vitamin D deficiency has several risks and no known benefits, leads me to conclude that when it comes to vitamin D, we should apply the primo non nocere principle, which in this case means avoiding and treating vitamin D deficiency in our patients. It was a real pleasure. Sas Eucharisto.